Okay, Assalamu alaikum. Good afternoon, ladies and gentlemen. I would like just to thank the organizing committee for the kind invitation. So I'm going to talk about the smart monitoring that's available in our hospital here in Saudi Arabia, especially intra-op. As you see, this is like a typical monitor that we see in every OR, and you can manage, different kind of patients, including shock and septic patients, high-risk patients as well. If you see this one, for example, the ECGs, the ECG is a very, essential monitor that we use in anesthesia practice. And as you see here, that this require, either the placement of the leads, either 3 leads or 5 leads in different parts of the chest. The problem, of course, sometimes you face difficulties, especially, if you have a patient who's with multiple, risk or multiple devices also available, like LVAD and this one, or certain, type of the chest. To detect ischemia, the issue with ECG, it has high negative predictive value. The problem with positive predictive value is limited. You need another test or modality to use. What is new I would say is like now as a new innovation, probably that we will have 2 leads ECG instead of 5 leads ECG that will give you the same information of 5 leads. It will be convenient, especially in certain patients with devices or patients with post-op patient. What about CVP, SAT? Pulse oximeter is also another essential parameter that we use in the OR. The advancement here of pulse oximeter now, that those devices now, they give us information more than pulse and saturation. It can give us also total hemoglobin. This device, for example, from Massimo is available in most of the government hospitals, Ministry of Health hospital. The problem is the transducer or the probe, which is really sometimes expensive. You find it like it costs around 250 to 300 real. But it gives you good information. It gives you like variety of information that you can guide, for example, non-invasive hemoglobin monitor, and also the similar to the variability that you can predict when to give fluid to the patient. Blood pressure is also essential, and we usually use the invasive, which could give us continuous blood pressure monitoring. The advancement now that you can have pulse oximeter with information about non-invasive or minimal invasive cardiac output monitoring, stroke volume variation. What does this mean? It means like you can predict for your patient, if you give a fluid challenge, that this blood pressure will improve. And it can give you the information. Different companies available now, and it's all these technology available in our hospital in Saudi Arabia, where you can have the stroke volume variation. This is like the most important terminology that can predict whether you will have, your patient will respond to fluid challenge or not. PA pressure, as you see, the pulmonary artery, people move away from pulmonary artery, but still we use the pulmonary artery catheter in certain patients, especially liver transplant, heart transplant, certain high-risk patients with pulmonary hypertension. What is the advancement now? You have Swangans with continuous cardiac output monitoring, with least intervention possible, so it can give you continuously the cardiac output and this one and other information. The problem with this monitor, of course, is that you need a separate device or monitor, but it is also available in Saudi Arabia. The cost also is an issue. The temperature monitoring is important because you see the patient, if he is or she is cold, then this risk of bleeding and plus other reported information, plus other complication that can happen with hypothermia. Fully catheter with the temperature probe, it will give you a continuous temperature monitoring, not only in the OR but also in ICU as well. Of course, we focus on the awareness during anesthesia, especially if you have a high-risk patient and you are exposing this patient to anesthesia. People tend to reduce the dose of anesthetic so it will not affect the hemodynamics. Using BIS monitor to give you an idea about the brain, and it will actually measure the EEG and awareness, and it will prevent the accidental awareness, and also it will give you the level of anesthesia and sedation. This is also important because you see, in many cases, cardiac surgery and also thoracic surgery, it was reported of accidental awareness during the general anesthesia. This is not only in the OR, but it can also be helpful in the ICU, where you can measure your sedation. So because we now focus on ERAS, which is enhanced recovery after surgery, we want our patient to wake up nicely and to avoid excessive sedation. Cerebral oximetry is another tool that we use to monitor the brain. You know, we want those patients, when we expose them to anesthesia and surgery, so they will recover, they will have less cognitive dysfunction, they will have less delirium, and of course, less stroke. And this device is also available. The issue also that if you weigh the cost against the benefit, of course, you know, these devices are important. You can also, you know, monitor your patient, and you can give the patient, for example, blood transfusion based on decrease in cerebral oxygenation. Coagulation management is like, we know that we measure ACT, for example, for cardiac surgery patient, for you know, patients who are really on ECMO. But now the advancement here that we can not only measure the ACT per se, but also we can measure the heparin concentration. And we can measure and we give heparin according to evidence, according to what the patient needs, not only with a single number. Bleeding management is also revolutionized. So we have patients that they come with different, you know, coagulopathy, and now we can detect what component of the coagulation is missing. For example, is it platelets? Is it FFP? So we can also measure those ones. Of course, ultrasound is an essential tool. We use it for central line insertion. Also, we can use it for, you know, fluid assessment of the patient. Finally, the echo. Echo is an essential tool. Echo, we use it now in cardiac anesthesia routinely in our practice, and it becomes like you know, a standard of care. The issue, of course, you know, if you want to be what we call a perioperative echocardiographer, of course, this will require, you know, cardiac anesthesia fellowship. It requires training. It requires also supervision by the expert. Thank you very much for listening.